Okay, well, welcome everyone to our Alberta Transplant Institute's rounds today. I'm glad you all could make it. I first want to acknowledge, and the Institute wants to acknowledge, that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I also want to thank Paladin for their continued support of the ATI seminar series. And I also am excited to invite you to register for the ATI Research Day 2025 happening on March 26th. And the registration link will be placed in the chat. So today I have the privilege of introducing Dr. Dmitry Rozenberg. Dr. Dmitry Rozenberg is a respirologist at the University Health Network and is affiliated with the Ajmera Multi-Organ Transplant Program in Toronto. He is an assistant professor in the Department of Medicine, University of Toronto. Dr. Rozenberg's research aims to understand the impact of physical fitness and skeletal muscle function on daily physical function, quality of life, frailty, healthcare use, and survival before and after lung transplantation. As a respirologist with undergraduate training in kinesiology, Dr. Rozenberg is looking to translate his clinical experience and passion for exercise training to improve health outcomes in individuals with lung disease and across the multi-organ transplant program. And we have the fortune in our lung transplant program to be collaborating with Dr. Rozenberg on one of his clinical trials as well. So today, Dr. Rozenberg will be presenting on clinical implications of prehabilitation in lung transplant candidates. Thanks, Dmitry.
Thanks, Dr. Vergusi, Ria, much appreciated for the invitation. Always a pleasure to talk on this topic, and just going to hide this meeting control and tell you a little bit about one of the trials that we're embarking on together across Canada, which is quite exciting. Just as a disclosure slide, I do receive research support that's relevant to this talk from the Sandra Fair and Yvonne Feakin Professorship, and also the Faculty of Medicine. And the work that you'll hear about the IMT project has been funded by the Canadian Institute of Health Research project grant. And I will discuss the use of PowerBreathe device as it applies to the trial. All equipment has been purchased by the grant money, so no other financial disclosures. So the main objectives for today's talk are threefold: to describe frailty and physical function in advanced lung disease and transplant candidates and their association with clinical outcomes, to highlight several rehabilitation strategies in advanced lung disease and transplantation, how the landscape has evolved post-pandemic, and also outline ongoing Canadian multi-center clinical trial of inspiratory muscle training towards the latter part of this talk, which we're hoping to onboard. We started at the UHN site, but we're hoping that the other sites will come on board throughout March to June of this year as we're finalizing contracts. So as many of you are aware, there have been multiple advances in the field of lung transplantation over the last 3 decades. Based on ISHLT registry data, there's about 4,500 transplants conducted per year. And we know that lung transplantation improves quality of life, exercise capacity, and survival in people with advanced lung disease. However, given the increasing age of the population that we're transplanting, there are increased comorbidities in some of the candidates that we see, and also sometimes functional impairments at play. And so hence the importance of rehabilitation. As you can see from this slide, that's a few years old, but the trend is certainly quite there from the ISHLT. You can see on this blue median age increasing over the last 2 to 3 decades. And on average, we're seeing more candidates above the age of 65 now that we're transplanting. It will certainly be quite variable across Canadian centers, but also internationally as well. And as an international community, it's well recognized that optimal selection of lung transplant candidates is quite critical in terms of improving morbidity and mortality with transplantation. The 1-year mortality varies across North America and internationally, but on average, it's around 10 to 20% within the first year in all comers. And pre-rehabilitation established an important modality to hasten recovery post-transplantation and improve frailty pre-transplantation. And most centers across Canada and internationally have some form of recommendations for pulmonary rehabilitation or a dedicated rehabilitation program. And these are the two documents that may be of interest to this group and certainly quite important to the lung transplant community. This was a document by Leard et al. A few years back that proposed the importance of selection of lung transplant candidates. And they highlight that frailty and pulmonary rehabilitation need to be considered within the concept of lung transplant candidacy. Furthermore, Joanna and colleagues, fortunate part of this group, had proposed that frailty and aging-associated syndromes in lung transplant candidates and recipients is quite an important element, and describes some of the immunological senescence that comes along with frailty, and do highlight the importance of rehabilitation as well, which I'll talk about. So, I mentioned the term frailty, and the reason I start off with frailty is because it really encompasses both physical and functional parameters, as you'll see throughout the talk, and some of the considerations as we move forward with rehabilitation. However, in general, frailty, as proposed by Jonathan Singer and colleagues, represents a generalized vulnerability to stressors resulting from an accumulation of physiologic deficits across multiple interrelated systems. So oftentimes we think of frailty as more of a physical impairment, but as you'll see, it also encompasses cognitive, physiological, and immunological parameters, as well as important prognostic implications as well. And so just to illustrate this point of frailty is in red here, you can see if there's a perturbation, such as an exacerbation, a respiratory exacerbation, an individual that's frail may not necessarily bounce back to the same degree after a hospitalization, for instance, pre-transplant, as someone who's more robust and not frail. There are a number of considerations when we think about frailty across the spectrum of advanced lung disease in our lung transplant candidates. So specifically, there are the physical measures comprising frailty that we're quite familiar with and have important prognostic implications. So specifically, things like functional capacity, i.e. exercise capacity, now comorbidities, such as osteoporosis, cardiovascular disease, contributions of chronic inflammation and nutritional status, and body composition is quite important, physical activity and functional capacity, and then skeletal muscle dysfunction, which I'll touch upon briefly for limb muscles, and then highlight the importance of respiratory system in transplantation, which in the lung transplant field hasn't received as much attention over the last decade or so. And then psychosocial measures are quite important as well, including mood, social stressors, and cognitive impairment. So we know from other populations outside of lung transplantation, frailty is certainly important. In older adults, community dwelling adults, frailty is associated with falls, disability, institutionalization. Postoperatively, in general surgical procedures, it's associated with postoperative complications. And in cardiac patients, it's associated with increased healthcare utilization, the need for LVA, left ventricular assist device implementation, and some work that's emerging, as you'll see, in the lung transplant field has been associated with outcomes pre and post-transplant as well. Further, in advanced lung disease patients and candidates, it's associated with increased disability and risk for exacerbations. And there's a very nice relationship that's being established between frailty, dyspnea, and physical inactivity as well, when we think of our advanced lung disease population. So there are a number of models, which I'm not going to go into too much detail, but I do want to introduce the models briefly to make sure everyone's on the same page when we're talking about associations and outcomes. So the most common model that's been described in the literature is the phenotypic model of frailty, which is the Fried Frailty Index proposed in the early 2000s by Fried and colleagues in the cardiovascular health study, and really examines 5 phenotypic features: weakness, exhaustion, unintentional weight loss, low gait speed, and low activity levels. And really, when we think about this model, it's really more of a physical model that's amenable to traditional rehabilitation strategies. Furthermore, work from COPD populations, community dwelling populations, and also work from Jonathan Singer and all, has shown that the short physical performance battery can be utilized as well as a marker of frailty, looking at three domains, essentially each one scored out of 4, balance, gait speed, and chair stance. And then there's the cumulative deficits approach that Rockwood and colleagues have proposed. It's been applied across a number of populations, including the lung transplant cohort that's and Dr. Varagousi has looked at this, and also Leanne Singer. But essentially, really looking at a number of deficits, including clinical characteristics and laboratory measures, and the number of deficits, the great number of deficits, the increased burden of frailty. And many of you may also be familiar with the clinical frailty scale, which is a subjective interpretation by the clinician on a scale of 1 to 9, and also similarly the Edmonton Frailty Scale, which is out of 18, which I'll highlight shortly as well. When we think of the pathogenesis of phenotypic frailty, that frailty phenotype in our advanced lung disease population, many of our patients that come for lung transplantation to some degree have underlying lower skeletal muscle weakness, some element of cachexia, potentially physical exhaustion, slow gait speed, and low activity levels. And so it's this circular pathway which we're trying to break through rehabilitation strategies of both aerobic and strength training exercises and appropriate nutritional supplementation. And so you've got your chronic lung disease state, got your low muscle mass or sarcopenia and a negative energy balance, potentially some cachexia at play. And as a result, resulting in reduced lower extremity strength and power, and including walking speed and total energy expenditure as well. So it's through these rehabilitation strategies that we try to offset this balance, including improvement in strength, improvement in activity levels, and also improvement in the nutritional status. Similarly, with the cumulative deficits model, which goes beyond the physical limitations that are captured in the phenotypic frailty model, but really captures the cognition and mood and social vulnerability aspects as well, which we're able to potentially intervene, as I'll show you some work evolving in the cognitive mood state and a nice review article that's recently come out that we are able to modify with pulmonary rehabilitation some elements of cognition and mood as well. And similarly, as I highlighted, the clinical frailty scale, which is a subjective interpretation of frailty, and then the Edmonton Frailty Scale, which has 9 criteria, as you can see here on a scale of 18, which I'm not going to go through, but really is able to characterize different degrees of frailty in the clinical setting to help us determine the risk that this individual may pose for procedures and such as lung transplantation. So, when we think about frailty, what are some of the key elements that are intertwined in frailty that I've mentioned so far that could be potentially amenable to rehabilitation strategies, whether it's in the home environment or whether it's in an in-center pulmonary rehabilitation program? Well, the traditional measures that we're quite familiar with are gait speed and exercise capacity, which we know are amenable, physical inactivity, skeletal muscle dysfunction, cognition, and mood as well. And given the interest of time, I've just selected a couple of key aspects that are important to consider in the pre-transplant period if we're dealing with an advanced lung disease population or lung transplant candidate, because these are markers that one could measure throughout the rehabilitation course, but have also been shown to be important prognostic markers that are amenable to some form of exercise training. So we're all familiar with the 4-meter gait speed. It's been utilized quite a bit in the free frailty index, but furthermore is also a marker of prognosis in both COPD and ILD populations as a prognostic marker, and certainly an important element of that phenotypic index, as you'll see, that's been prognostic of outcomes. And then the 6-minute walk test has been a universal field test that has been utilized in North America and internationally as well, and really helps prognosticate outcomes both in the pre and post-transplant period. But more importantly, it is amenable to improvement with treatment. Similarly, just to highlight that our lung transplant candidates, on average, this work from Lisa Wickerson and all, have significant decreased levels. As you can see, males slightly higher than females, and this is predominantly an ILD lung transplant population. But here are the Canadian normative values, where this being around 9 to 10,000, whereas the lung transplant candidates, even though they're participating in pulmonary rehabilitation at our center, and this was a few years back, obviously, in person 3 times a week, they were still around the 3,500 mark to 2,000. Highlighting, the reduction in daily steps that these lung transplant candidates undertake in their daily function as a result of their respiratory illness. But more importantly, 6-minute walk distance is a very important determinant of low physical activity. And so they're intertwined. So ability to kind of improve their exercise capacity and physical activity steps could improve their functional capacity as well. And then work that I've done throughout my PhD now a few years back, we really showed that skeletal muscle dysfunction is an important element comprising physical frailty, but it's certainly quite prevalent in lung transplant candidates, specifically lower extremity dysfunction, which has been shown to be an important marker of early post-lung transplant outcomes in terms of hospital length of stay, and has been associated with quality of life, activities, daily living, and exercise capacity. And this includes both limb muscles and also thoracic skeletal muscles as well, characterized with CT morphometric analyses as well. And then an emerging field that's important to highlight that certainly impacts physical frailty and also frailty in general is cognition and mood. So we know that there's quite a bit of variability, more studied in the COPD patient populations, that cognitive impairment at play, such as attention, memory, and executive function could be impaired. And the ranges are quite broad, just highlighting that from 25 to 75, at least one domain, attention, memory, including things like dual tasking impairments, which is the ability to do 2 things at once. So the shortness of breath that these individuals experience can affect their ability to perform multitasking in the home environment. So, for instance, crossing the street and talking to someone. And we know that respiratory exacerbations, which are so common in the lung transplant candidate population, can impact both cognitive and physical decline. However, as I mentioned recently, and this was an update on a previous systematic review that was done a few years back, looking at 9 RCTs that were performed, that with aerobic and strength training exercises, predominantly in the COPD population, you can improve at least one domain of cognition in these patients with exercise training. And so just to kind of highlight, we went through many of the key elements of frailty, physical frailty, and the cumulative frailty. But important to highlight that the literature has shown that the freed frailty index, for instance, in the lung transplant populations has range. So there are studies that have shown that it's prevalent in 19% to 32%. So quite a range, but really gives you an idea that it's about 1/5 to 1/3 of patients that are listed for lung transplantation, usually applying the freed frailty index. And then when we applied the cumulative frailty index across a number of patient populations, advanced pulmonary arterial hypertension populations, interstitial lung disease, similarly in COPD and lung transplant populations, we're seeing that it's around the 35 to 50% mark, slightly higher, utilizing the cumulative frailty index as opposed to the phenotypic index. And this would capture comorbidities, laboratory, and functional assessments. Irrespective of the index that's measured, and there's a lot more literature that's been published on the freed frailty index. It's been taken up in advanced lung disease and lung transplant. It's certainly associated with outcomes both pre and post-transplant. This is a landmark study by Jonathan Singer that many of you may be familiar with, originally published in 2015 in the Blue Journal at combined 4 centers across the US, predominantly ILD and COPD population, as we typically see in our lung transplant cohorts. And the prevalence was around 28% with the freed frailty phenotypic index, and short physical performance battery of around 10%. And in this cohort, both freed frailty index and the short physical performance battery were associated with increased hazard risks of delisting or death. And here are just the hazards ratios. For every 1 point out of 5 increase in the freed frailty index, there's about a 30% increase in delisting or death. And same thing for the short physical performance battery. So quite significant improvement, and a decline in these values, so lower scores in the freed frailty index and short physical performance battery. Similarly, work that's been done out of our center at UHN here during the PhD, collaborating with Dr. Leanne Singer, one of the co-supervisors, Sunil Mathur at the time, We had looked at a retrospective quality of life database that Dr. Singer had developed over the years. And essentially, we wanted to look at the prevalence prospectively in 50 lung transplant candidates using 3 phenotypic models, which had good agreement between them, including the Fried Frailty Index. And then we applied one of the phenotypic index models in a retrospective fashion to 221 lung transplant patients in our center. And we were interested in evaluating quality of life and functional recovery post-transplant. And as you can see here, in around 220 lung transplant recipients, in red is the frail and not frail, in both of the St. George total respiratory score when we adjust for age, sex, and diagnosis. There was a significant improvement, lower scores being better. There was a significant improvement by 10 points on total storage respiratory questionnaire relative to the non-frail group when we adjusted for these covariates. And similarly, a greater improvement in the 6-minute walk distance for frail individuals pre-transplant. Suggested that there's significant rehabilitation potential and also significant improvement in quality of life and functional capacity post-transplantation. And then Jonathan Singer and his group had highlighted the physical functional side of things and the improvement in close to 246 patients in their prospective cohort study. As you can see here, the short physical performance battery improves post-transplant, the vertical line here representing transplantation time. And then similarly, also a significant improvement in the first 6 months as well with the Fried Frailty phenotype, with 84 transplant survivors becoming not frail after transplantation. So to summarize this section, frailty is prevalent, ranging from 20 to 50% of individuals with chronic lung disease. There are a number of associated physical, psychosocial, and functional contributors to frailty. And frailty is associated with worse quality of life, physical function, increased healthcare utilization, and pre-transplant delisting and mortality. And certainly some work that's evolved from the body composition study as well that was published in 2018 that I didn't mention had shown increased mortality in the first year post-transplant as well. However, there's a good signal suggested that physical frailty is modifiable in transplant candidates with rehabilitation. So this brings us to our second objective of the presentation, to highlight several rehabilitation strategies in advanced lung disease and lung transplantation and their effects on frailty, symptoms, physical function, and clinical outcomes. So just a quick summary based on the most recent guidelines and other guidelines. We know that pulmonary rehabilitation is beneficial for individuals with chronic lung disease and certainly applicable in the lung transplant cohort. We know that it improves dyspnea, exercise capacity, and limb muscle strength, improves quality of life, and reduces hospital admissions and mortality risks after hospitalization. And evidence is strongest in the COPD population, but benefits have been recognized in other chronic lung disease populations, such as interstitial lung disease and interstitial lung disease and pulmonary hypertension patients as well. And I'll get into the respiratory muscle strength. The document by Spruit and all does highlight some benefits in the preoperative settings, but the most recent iteration guidelines don't actually discuss respiratory muscle strength in the guidelines. So based on the traditional rehabilitation papers that we have in lung transplantation, and when I say traditional, I mean in-person rehabilitation, because most of the studies up until the pandemic, as you can see from this review article, have all really been in person. And I've varied study settings and duration of rehabilitation, with most centers doing rehabilitation up until the time of transplantation. But as you can see in the trials, a lot of them have been 3 to 16 weeks. Frequency has been 2 to 6 times per week. The type of exercises have been variable, ranging from walking programs such as treadmill or Nordic cycling, resistance exercises, but no studies to date have evaluated inspiratory muscle training, which we'll talk about later on in this talk, and then intensity and time not always described. However, with all of these various study designs and settings, the main findings that the majority of the population, there's been a significant improvement in the 6-minute walk distance in the majority of studies, 7 out of 9 studies. But others have shown maintenance, which is still impressive given that this is an advanced lung disease population with the progressive lung disease. And certainly quality of life has been shown to be improved with rehabilitation. However, there limited or few studies that have evaluated the effects of pulmonary rehabilitation on post-transplant outcomes, which I'll highlight one study that was retrospective from our center led by Leanne Singer, highlighting the importance of rehabilitation on hospital length of stay, specifically 6-minute walk distance. With these studies to date, there have been no adverse effects reported. And generally, anecdotally and clinically, rehabilitation is quite safe, both in the home environment and in-person settings with appropriate supervision. In terms of pulmonary rehabilitation in lung transplant candidates, this is the retrospective cohort study led by Leanne Singer and team. We looked at a whole cohort of 345 lung transplant candidates over a 5-year period. And this was in-person rehabilitation from 2004 to 2009. And 6-minute walk distance was relatively preserved in this population. Didn't meet the minimally important difference. And quality of life measures did progress as well, given the progression of the disease. However, both the treadmill speed and the muscle biceps training and quadriceps training volumes had improved, and a greater 6-minute walk distance that was achieved pre-transplantation translated to a lower hospital length of stay. So for every 100-meter improvement in 6-minute walk distance, there was a 2.6 fewer median days in the hospital, which is quite informative and important, highlighting the importance of rehabilitation in our lung transplant populations. Similarly, with the COVID pandemic, it's important to highlight that for all of those studies that I've shared with you were mainly in the in-person settings. And with the COVID, most centers had to transition rapidly during COVID. And this is an example led by Lisa Wickerson, who described about 100 patients. So most of them were lung transplant candidates, 2/3. And we had to transition to an asynchronous remote monitoring system. And lung transplant candidates described good satisfaction and usage scores, which we're seeing to date. As well, we're using a different virtual hybrid model now, but and the functional outcomes were slightly lower than an historic center-based PR. However, there were a couple of barriers with early transition, and this is something that's also evolving through surveys as we study and emerge throughout the COVID pandemic. There's some barriers with technology in some participants. Exercise intensity can be quite variable in the home environment for some participants. And certainly equipment was something of a challenge, especially early on during COVID pandemic in terms of access and actually purchasing equipment. But to date, the optimal structure, that balance between in-person versus virtual, still remains to be determined. I do like to highlight this slide with our rehabilitation because it's quite applicable to our lung transplant populations and all advanced lung disease populations, as many of the programs now have transitioned to a hybrid model. And so we could see here by Holland and all, this is an ATS document that actually happened before the pandemic, but really even before then, they were thinking about patient assessment, what are the key program components, and then the method of the delivery, and whether bringing the individual in for that first assessment in person, and then how frequently do we bring them in subsequently as well. And then any rehabilitation program needs to have an important quality assurance measure. And so they kind of highlighted essential components of pulmonary rehabilitation, which are quite applicable to our lung transplant populations, which capture some quality of life measures, some dyspnea, nutritional status, both aerobic and resistance training, and being able to conduct this both in person or virtually. Further, as I mentioned, kind of looping back to our previous conversation about an older patient population, potentially with slightly higher comorbidities and higher risk for frailty. This was a working group document that I was part of, led by Matthew Maddox and all, and really describes this frailty rehabilitation paradox, that in fact, that pulmonary rehabilitation has been shown to be beneficial in individuals who are frail and can reduce frailty. But it's important to highlight that it's very challenging to get some of these individuals to the center or complete the rehabilitation program. And so it's very important to invoke multidisciplinary supports, geriatrics, palliative care, and provide a comprehensive assessment. And more importantly, expand assessment of frailty beyond physical dimensions and focus on novel delivery strategies of pulmonary rehabilitation was highlighted as well, which is quite applicable. And this is the landmark paper by Maddox and all that really highlights that phenotypic frailty model, when we take advanced COPD patients with moderate to severe COPD, before rehabilitation with their traditional 8-week program, 26% were frail, a quarter were frail. And then after rehabilitation, you can see this gray dark line really shifted and was kind of in that 10% range or lower. But certainly we know that frailty is associated with not starting or completing pulmonary rehabilitation, but rehabilitation outcomes are favored for frail completers, those that are frail. And so it's really important for us to consider how we're delivering rehabilitation to these individuals, including our lung transplant candidates, and more importantly, try to provide additional supports as needed to really get them optimized in the pre-transplant period. Further, this is a qualitative study by Lisa Britton and all that a few years back that really conducted semi-structured interviews with 19 COPD participants and asked a number of key questions centering around themes of frailty status, living accommodations, ability to complete pulmonary rehabilitation. And one of the things that really emerged from the lived experiences of patients is, and the importance for us to realize, the unpredictable disruptions with respiratory exacerbations that our patients experience, conflicting priorities with other appointments, transportation, and caregiver responsibilities, and negative perceptions and heterogeneous symptoms could certainly impact their ability to attend the rehabilitation program. But also we need to keep this in mind when we're conducting the clinical research studies as well within rehabilitation, that we need to provide flexibility and ability to integrate them back into the structured programs as well, which I'll highlight subsequently. And just to finish off, this was a nice feasibility study by Jonathan Singer that conducted a pilot study in 2018, pre-pandemic, really looking at 15 participants on moderate to high oxygen requirements. And he highlighted with the home-based exercise program provided through a simple iPhone. The majority were able to complete the intervention, and furthermore, the short physical performance battery improved along with the frailty freed index in the majority of the participants. And so, from the descriptors, it appeared that the majority enjoyed the mobile health technology and it was well received and safe. And when we recently, we conducted this about 2 years back, but with recent discussions and we held a national meeting with the Canadian Donation Transplant Research Program led by Snida Sherry Logan and myself with over 30 investigators participating in telerehabilitation in one capacity, both clinically and research, along with our patient and family partners. And we really highlighted across solid organ transplant candidates and recipients, both adult and pediatrics, that telerehabilitation could potentially reduce financial and time constraints, increase accessibility. However, we did highlight that optimal structure of telerehabilitation programs was not entirely clear. And then digital technology in terms of access and literacy is quite an important element to consider when we're providing it to our solid organ transplant candidates and recipients. And further, a comparison to in-person programs are needed. And these were the main discussion points that emerged from the telerehabilitation side of things. And this paper hopefully will be available online in the next few weeks. It's currently under review with resubmission. And so just to kind of summarize, when we are thinking of telerehabilitation, which has emerged as a new concept and certainly being applied broadly across Canada, across solid organ transplant and our lung transplant populations, we think about delivery methods. So what's the balance between hybrid or virtual? What are some of the barriers and facilitators? And then also, what about the digital tools and applications at play? And then not to forget the importance of evaluating both physical and mental health. And so this translates both to the clinical application, but more importantly as well, when we're conducting clinical research, as I highlighted as well, that we need to consider these delivery methods and ability to ascertain outcomes in our patient populations. So to summarize this section, skeletal muscle dysfunction, low physical function, and frailty are prevalent and key elements in advanced lung disease and lung transplant candidates. And prehabilitation offers an opportunity to modify some of these impairments. And telerehabilitation, remote patient monitoring for pulmonary rehabilitation is certainly evolving. And there's an opportunity to explore other modalities of rehabilitation in lung transplant candidates. And I'll highlight over the next 10 minutes, CICHR funded study that's sponsored by the Canadian Donation Transplant Research Program and huge initiatives from multiple sites. So we have the UHN site participating, Vancouver, Edmonton, and Montreal, and I've listed the co-PIs at each of the sites, and Ria Vergusi is the PI, principal investigator at the Alberta Edmonton site, and here are the co-investigators. And really the justification for this national trial in lung transplant candidates was the fact that the lack of literature in respiratory muscle training as it relates to the lung transplant population. And also that by Spruill, that guidelines document that came out in 2013 that highlighted there may be some benefit with inspiratory muscle training early on. We know that recovery after lung transplantation, as I highlighted earlier, can lead to difficulties with prolonged mechanical ventilation and protracted ICU stay, increased morbidity and mortality as well. And some work from Dr. Gallagher and colleagues, one of the co-PIs on this grant, really showed that early on at the time of liberation from mechanical ventilation, and you can see on this plot, if you have low diaphragmatic thickness, outlined in this blue bar with ultrasound measures, your probability of being liberated from mechanical ventilation is much lower. And this was across solid organ transplant populations. And so it's very important to realize that diaphragmatic structure and function at the time of initiating mechanical ventilation is a key determinant of outcomes of respiratory failure. As I highlighted that document from the ATS from Spruill in 2013 that suggests some benefit prior to major surgery as a consideration. And we know that preoperative IMT in patients with even normal maximal inspiratory pressures have been shown to decrease postoperative pulmonary complications and shorten hospitalizations after cardiothoracic surgeries. So in things like coronary artery bypass grafting and thoracic malignancies. And some studies in lung transplant candidates have shown that diaphragmatic twitch force reduced and mobility with ultrasound is impaired as well. This is predominantly in advanced lung disease populations. And some work out of my PhD had shown that even the majority have preserved maximal inspiratory pressure, but still have significant impairments in quality of life and correlations. But about 1/5 of these individuals had a reduction, at least one standard deviation in their age and sex predicted maximal inspiratory pressures. Before I get into the objectives of our trial, which I do want to highlight this guy. I apologize. We did some preliminary work at our center looking at the feasibility of doing inspiratory muscle training. So using this K5 device from PowerBreathe. And we wanted to see in patients with very high oxygen requirements who have significant coughing, could they train for 2 sessions, 30 breaths per session, 5 days a week for 6 weeks? And what was their satisfaction scores? So we had out of 25 ILD lung transplant candidates at our center, we had 13 who were able to complete 6 weeks of rehabilitation. However, about 4 had dropped out due to intolerance. Some of them were transplanted before completing the 6 weeks, so we don't have all the data, but the ones that were able to participate in the trial, we had satisfaction scores after week 1, week 3, and 6. The majority had very good satisfaction scores, 9 out of 10. And when we evaluated endurance, there was a significant improvement in endurance by 3-fold in their muscle endurance assessments that we conducted at baseline weeks 3 and week 6, suggested that majority of these patients tolerate the inspiratory muscle training reasonably well. And this was in the ILD population. Similarly, colleague Daniel Langer had conducted this in Europe in advanced COPD patients with severe COPD, looking at inspiratory muscle training and rehabilitation with 2 arms in a randomized controlled fashion. These were non-lung transplant candidates. And they really looked at the primary outcome of improvement in 6-minute walk distance. They did not see an improvement in 6-minute walk distance with inspiratory muscle training. But interestingly, what they found with standard rehabilitation and combination inspiratory muscle training, they had noticed an improvement by 75 seconds in their endurance cycling time, which is clinically significant, and similarly with the dyspnea work assessment as well, suggesting that inspiratory muscle training is a nice adjunct that could be considered. However, the lung transplant population is unique in a sense that our populations have severe respiratory failure, high oxygen requirements, and unique perioperative management needs compared to other surgical populations where the literature lies. And so this brought us to our CIHR funded study that really set out to have 3 aims: to evaluate the feasibility of a multi-centered RCT of preoperative IMT and lung transplant candidates in terms of recruitment, retention, program adherence, and ascertainment of clinical outcomes across COPD and ILD patients, and to establish the change in pre-transplant dyspnea, perception, diaphragmatic structure and function, and health-related quality of life, along with other patient-reported outcome measures and ability to ascertain transplant outcomes. Similarly, at our center at UHN, we're also characterizing the time of surgery with diaphragm biopsies as well to see the effects that inspiratory muscle training may have on the diaphragm. This is a multi-centered study. It's open label pilot and feasibility RCT, and it's IMT and whole body exercise training versus exercise training alone. And exercise training, whole body exercise training is standard of care across the centers, which we're characterizing quite closely. The inclusion criteria is 90 adult lung transplant candidates with COPD or ILD, and 50 will come from UHN and 40 from the other 3 sites, and they're undergoing standard pulmonary rehabilitation. Exclusion criteria will include respiratory exacerbations within the last month, any significant neuromuscular disease or cardiac pacemaker, inability, insufficient English fluency, and or French at the Montreal site, and any evidence of pneumothorax or pneumomediastinum, and rapidly deteriorating retransplant or inpatient status. In terms of the intervention, will be very similar to our feasibility ILD study, where we will provide a K3 or K5 device, which is a tapered flow-resistive device, which allows participants to really inhale with a little bit more ease than a typical threshold device. The plan is to do 2 daily IMT sessions of 30 breaths, less than 5 minutes per session, 5 days per week. And we'll start at 30% and progress them to around 70% of the maximal inspiratory pressure until transplantation. And we'll start, the IMT arm will have close supervision throughout the trial in their training, and data will be electronically stored on the device and similarly through diaries. And then the usual care will be tracked, and I'll show you the diagram at the same time points as well, every 4 weeks. Our primary outcomes will include feasibility, so can we recruit these patients and retain them in the study, adherence, which will also be tracked electronically, satisfaction and motivation scores, and then clinical outcome ascertainment as well. And the post-transplant outcomes will be ascertained in a blinded fashion. In terms of our outcomes, just very briefly, we'll be looking at maximal inspiratory pressure, diaphragmatic thickness and thickening fraction at UHN with ultrasound, endurance time, threshold loading, so baseline and every 4 weeks, various patient-reported outcome measures, including dyspnea, quality of life, and mood questionnaire, and physical activity, and the standard clinical lung transplant outcomes, including the ability to capture hospital-free days at 90 days. At UHN, we'll be capturing diaphragmatic biopsies at time of surgery. We've had a very good consent rate, around 50 to 60% interested for biopsy who've consented for the studies to date. We'll be evaluating histology, mitochondrial respirometry, and RNA. And this is work in collaboration with the surgeons and multiple members of the team. At the ICU, we'll be characterizing modified wind classification at time of mechanical liberation, and also be using a Marini maneuver to try to capture maximal inspiratory pressure at the time of mechanical ventilation liberation. And so to summarize the measurements, as you can see, we'll have multiple respiratory measurements and patient-reported outcome measures, and they'll be done at baseline, 1 month, 2 months, 3 months, 6 months, 9 months, 12 months, and every 3 months until transplantation. And then we'll have a time of liberation for mechanical ventilation, and then 3 months post-lung transplantation. Similar to what I've discussed earlier, we made sure to provide a lot of flexibility in the study and really only need participants at baseline at site to get the equipment and do the proper full assessments. And then subsequent assessments, they have the option of coming in center, or they can do them virtually. And similarly, we try to capture the participants again at the 3-month mark post-transplant in person. So in terms of progress to date, study was initiated at the end of August at UHN in 2024. We've enrolled 9 to date, and we have 3 more interested. We have data safety monitoring through the Canadian Donation Transplant Research Program with no serious adverse events or minor events, and anticipate enrollment at other centers starting in March to June of 2025. with the study going until September of 2027 at least. And so significance of this trial will be IMT may prove to be a simpler intervention to prevent post-transplant morbidity, and we liberate these individuals from mechanical ventilation earlier. And we would obviously do a more definitive study, and it will help us establish feasibility of potentially conducting inspiratory muscle training in the pre-transplant period, especially in those that may have low maximal inspiratory pressures. And also understanding the changes that occur in the diaphragmatic muscle, both strength, endurance, and at the histological level will be very informative. And certainly some of these techniques will be transferable to other solid organ transplant populations. So to conclude, frailty and advanced lung disease and transplant candidate is prevalent and associated with increased morbidity and mortality. And it's important to anticipate disruptions in pulmonary rehabilitation participation to provide additional support, and future research required in non-traditional forms of pulmonary rehabilitation as we emerge from the COVID pandemic, and how do we implement telerehabilitation in a safe and efficacious manner. And I'd like to thank the audience for listening and giving me the opportunity to present today. I'd like to thank the patients for providing their time and support, and all of the centers to help launch the CIHR-IMT trial, and the funding support for this trial as well. And open up the floor for questions. Thank you. And open up the floor for questions. Thank you.
Thanks, Dmitry, on this really interesting presentation. I'd just like to remind all of the participants that if you have a question, please raise your hand using the function in Zoom, or post your questions in the chat. So
I'll stop sharing the presentation. Thank you. Or
sure. And before Dr. Halloran's ready with a question, so Kieran, take it away.
Thank you very much. Nice to see you, Dmitry. Always enjoy following this body of work. You've done some great work over the years. So, you know, I know that the trial isn't specifically focused on telerehabilitation, but I'm always curious about telerehabilitation, because when you talk to patients who are years post-transplant, what they really take away, seemingly to me, what they really take away from that phase of care is the sort of group that they went in with, and they sort of establish these lifelong friendships, and it helps them with coping with post-transplant complications, and they follow each other often until you know one of them passes away, or and keeping in touch. So I'm wondering about if there's a way to quantify that, or a way to study that qualitatively, maybe to see what that piece missing, if it's missing from telerehabilitation, what the impact of that is on the patient experience.
Yeah, no, 100%. And that's a very important question across the solid organ transplant population. Pre-pandemic, the majority of the trials and the clinical care was all in-person rehabilitation. And, you know, that establishment of those relationships that you'd have with the cohort that you'd go through, both with the in-person rehabilitation, the transplant, the post, it's very hard to replicate, in my opinion, through a telerehabilitation model. Now, most telerehabilitation models, many of the research studies, including clinical care, and it's quite variable across the board, have really been asynchronous, meaning they're conducted offline with the therapist, and oftentimes is not always done in a group fashion. It may be one-on-one with the therapist. So in order to kind of combat some of this group dynamics that we're missing potentially, and they need to consider in order to provide motivation, self-efficacy with exercise training, I think some aspects of a hybrid program are essential. So bringing in participants early on, making sure maybe they are going through a similar group, bringing them back at particular time frames. When conducting telerehabilitation training, having a group of 4 individuals maybe that are aligned, that they're able to kind of join together and stay on the line and exercise independently through the telerehabilitation strategies. And then subsequently, just providing some social opportunities as well. And so those are just some considerations to take away, but those are going to be very important to study both on the research side of things, but also implement on a clinical basis, even before the research is available. Most studies, though, to date have really been mainly asynchronous and 1 or 2 participants. So it's something to consider as well as we move forward.
Thank you.
So I had a similar question with telerehabilitation and friendships, but when looking at rehab, most of our rehab up to this point has really focused on making sure people can gain mobility fairly quickly after transplant. So a big focus on the legs, sit to stands, and making sure that those quads and the hip flexors, etc., can help lift you up, and some focus on the arms. How important is it to be looking at other muscle groups to improve overall function? And do you think we have been focusing on the wrong thing all this time?
No, it's a good question, Ria. I mean, I think you can't discount the importance of lower extremity dysfunction in our advanced lung disease population. I think if you were going to do one form of training, I think the lower extremity is probably one of the most important elements that you can optimize a pre-transplant. Just because there's a body of work from the advanced lung disease populations, like quadriceps size and strength, whether it's an ILD or COPD, are important prognostic markers outside of lung transplantation. Some work that we've done at our center and others, it's an important element of liberation from mechanical ventilation, because quadriceps strength is a kind of a global assessment of well-being. However, with that said, though, you do need to train whole body. You can't just focus on the lower extremities. Upper extremities are generally more preserved in our population because with activities of daily living, patients with advanced lung disease still participate in self-care, right? Brushing their hair, lifting arms, doing some kitchen chores. In terms of the effects of the respiratory muscles, it's a little bit hard to pinpoint at this stage because there's so many factors at play. But the hypothesis here is that at some level, irrespective of whether their maximal inspiratory pressure is preserved, there is some element of diaphragmatic dysfunction from the ILD populations, the COPD populations that we've seen, that could be improved with training. And certainly the evidence that we see in the coronary artery bypass literature, and also with the surgical oncological populations, could help with liberation from mechanical ventilation. Now, if you liberate someone from mechanical ventilation, work that Margaret Herridge and colleagues and others have done, the earlier you get them off the ventilator, theoretically, the better they do, right? And so this is a very important consideration to improve physical function.
Thanks, Dmitry. Kieran? Kieran, you're still on mute.
Sorry about that. So specifically with respect to your trial, Dmitry, so I'm wondering, how are you going to handle, because it's pretty small numbers, I realize it's pilot design, but how are you going to handle surgical variants in diaphragmatic parameters post-transplant? Because, as you know, we see lots of phrenic nerve dysfunction, phrenic nerve injury. We see significant variance in between surgeries in terms of what's been done, like a decortication, depending on what adhesions were present at the time of surgery. It seems to me like a lot of that could confound the outcome measurements. So how do you plan to handle that in the analysis phase, and if at all, and moving forward into a larger trial?
Yeah, no, it's a very good point, Kieran, that you bring up. I mean, there's a lot of confounders there for sure. I mean, one of the things we wanted to reduce the background noise is we just have COPD and ILD group. Now we're obviously not restricting to the type of transplant. And we will be characterizing in a detailed fashion number of exacerbations, whether these individuals required ECMO, whether there were surgical complications, it's very hard to characterize the phrenic nerve dysfunction outside of, we're not doing any particular assessments of that. We will capture that if that was the case in the clinical chart. But we're hoping with a randomized, first of all, it's a feasibility study, but we're hoping with a randomized fashion that some of that variation may balance out potentially. We are randomizing based on site and also based on type of lung disease. So we're hoping with the stratification, even though it's small numbers, it'll balance out. But certainly for the definitive trial, we'll need to think about that a little bit more once we get this preliminary data, because that could be a significant confounder in terms of clinical outcomes.
Thank you.
Okay, well, I have one last question. So lung transplant in Canada has been pretty siloed between our centers, and now we have a growing few trials that are being done between all of our centers. What have some of your challenges been trying to operationalize this type of a trial?
Thanks, Rhea. I mean, to my knowledge, I think this is the first rehabilitation trial across the 4 transplant centers. So I'm quite excited about that. Someone who's obviously very passionate about rehabilitation. In terms of the challenges, I mean, it's the standard challenges that you experience whenever doing a multi-centered study. The contracts do take some time, but we anticipated that and taking that into a timeline. Having the data safety monitoring board and the CDRP in place will help us standardize things from a safety standpoint and making sure. I think for this trial specific, we need to be mindful that the standard of care rehabilitation strategies are quite different across centers. Vancouver, Edmonton, Toronto, Montreal. However, with that in mind, at every 4 weeks, we're making sure, in addition to whatever they're doing clinically, we're capturing exactly what they're doing with respect to rehabilitation, patient report, and through clinical chart review. So that is going to be an important descriptor in the trial, because someone participating in rehabilitation once or twice a week in the home environment may be very different than someone doing rehabilitation 3 times a week. We need to be mindful of that and characterize that. And then we've tried our best as much as possible throughout the trial to harmonize all of the equipment. And so that, and making sure it's all approved within Canada and safe to use. So that's something that took some time as well. Yeah, looking forward to this trial. Those are some considerations.
And we're looking forward to joining you. So now looking at